Thank you. Okay, so no conflicts of interest. So let's get started. So this is a 52-year-old native Hawaiian female. And around Christmas time, she started presenting with nephrotic syndrome. She had proteinuria before, presented with a creatinine of 2. Has a pretty extensive history of Metz connective tissue disease, treated with Plaquenil, and has a solitary right kidney. She actually had a nephrectomy when she was 13, ended up being a benign mass. So this is kind of just showing the increase in proteinuria. I'm not very good on computers, so let me just see if how does the mouse work?
Get the mouse pointer.
Yeah, I'm sorry.
Yeah, probably the mouse pointer that way our viewers on Zoom can see.
Yeah, sorry about that.
There.
Okay. All right, thank you. All right, so increase in proteinuria. This is 1A, 110. So quite a bit of proteinuria at this time, nephrotic syndrome. She has a solitary kidney. I'm not a radiologist, but the kidney is enlarged when they came in. And actually, it's very enlarged. And the very first thing that they did was put in a nephrostomy tube. So she comes in, she has a creatinine of 2, nephrostomy tube, nephrotic, and then they get a whole bunch of labs. And her ANA is positive. Double-stranded DNA is indeterminate. It's been positive. Sometimes it's negative. Positive Smith antibodies, which go with lupus, RNP antibodies, which can be seen in it. And just to show her double-stranded DNA, it's been marginal, positive, kind of on the edge. Complements are low. So it looks like something is active here. So it's a very complicated case. First off, she has a solitary kidney. Secondly, she now has a nephrostomy tube. And she has what looks like she has nephrotic syndrome, but at the same time, they're very hesitant to do a biopsy because she has a solitary kidney. There could be an active component of lupus, which is pushing you to biopsy, versus just see what happens. And this is the very first time I've ever seen anybody say this. Well, why don't we just start treating? We're giving some steroids. And then if urology says it's okay, you know what? We're starting with MMF. And if that does good, we'll just keep going without having any tissue diagnosis. It's kind of a very different way to see things. So she came for a second opinion. And when she came for a second opinion, they looked and they go, look, if there's something active here, we can do something about it. If there's not, then at least we tried. So this is the kidney. The very first thing, it's always bad when you don't show with magnification. This is 400x. The kidney is enlarged. The glomeruli are enlarged. Kidney is also enlarged, but the glomeruli are very enlarged. And very quickly, we see segmental sclerosis in a perihilar distribution. This looks like what you get from a solitary kidney. I mean, this is what we see in the old dog models and everything else. Moderate interstitial fibrosis, not an end-stage kidney. There's something to do here. And I get the IF. Negative IgG, negative C3, negative IgM, kappa lambda, everything's negative. I call the clinician and go, there's no active lupus here. So there's really nothing to treat. I'm going to get the EM. I'm going to rush the EM, but there's really nothing active here. There's no lupus. And then I get the EM, and I just see subepithelial deposits everywhere. And what do? I look at the silver, and I go, oh my God, how did I miss this? They're holes. I don't know what happened. I worked at Arcana for years. First thing we do, paraffin IF. So I called the clinician. I go, look, there's something active here. There's something to treat. I can't tell you definitively what it is. It looks like a membranous. They're mimickers of membranous, but this really looks like a membranous. So I do the paraffin IF. IgG, negative, A, M, C3, C1Q, kappa lambda. Everything is negative. I mean, I would push, I was hoping just for trace, just anything. And then I started going, wait a second, let me actually start looking at the EM and see what's going on here. So very first thing you notice all these little microspherules. And then you kind of see them taper off and go down. And then this is really kind of nice here. You see all these little microvilli, and they just kind of like disappear into the membrane. And I've been doing this for years now, 15 years. And I'm like, this is something I haven't seen. And then I keep looking, and it's just all these little microspherules. And what really caught my attention were the podocytes. These podocytes, or I guess the old word in Arkansas would be revved up. Tons of microtubules in them. These things are active. Look how many. I mean, this thing is just chock full of microtubules. So then my question starts going, what's going on here? Are these immune deposits that for just some reason don't stain? Or is something else going on here? And then I noticed, look at this microtubule here. It's the very same one that I saw in the podocyte. And this is beautiful here. I mean, you see the secondary foot processes, and then you kind of just see these microspherules just in space. And then you kind of just see them crawling down into the GBM. And so I'm completely lost. And the more you look, secondary process, right there, it almost ends up in a cup with these spherules. I started going, what is actually going on here? Is the disease in the membrane, or is the disease in the podocyte? And it's intriguing because if this was in the membrane, if these are deposits, they should stain for something. And I know the stains worked. And the more I look, the more I start questioning, are these actually deposits? Or is this an entity that's been described in Japan, podocyte enfolding glomerulopathy? A lot of controversy in this country about it. But could this actually be that entity? And this is just beautiful. You can't ask for better podocyte enfolding. Right there. And what we associate are microtubules and microspherules right next to it. Beautiful enfolding. So I do have an enfolding. So I know that's there. But the question is, are there also immune deposits that just aren't staining? And this is just a nice little illustration where we see the podocyte. And then you see it kind of just cupping in to the GBM. And this has been described. Just kind of goes straight in. So it enfolds and vaginates. To me, it burrows into the GBM. So this was actually first described, podocyte enfolding glomerulopathy was first described in 1992. And this is what I think of whenever I think of podocyte enfolding glomerulopathy. Just a few little places, but not much. And then in 2008, the Japanese Society of Nephrology, we actually have the head person, actually put this together, 25 cases, and they actually came up with a formal diagnosis of podocyte enfolding glomerulopathy. And they used three-dimensional reconstructed images of TEC-EM, very complex stuff. I'm not even going to say that I understand it completely, but they showed that each one of these microspherules connect back up to the podocyte. And you can't do anything without making a classification. It's just part of the game. So type A, you just see the enfolding. Type B, you see the enfolding with the microspherules. Type C, you just see the microspherules, microtubules at that point. So these are some of the images that we see from the paper back in 2008. And we see all these microspherules. And what really defines it is the podocyte enfolding. And it's kind of seen as a heterologous disease. That it's just not one disease. It's kind of a reaction to many diseases. Now, spherical microparticles is not anything new. They've been describing them since the 70s. Burkholder and all of them. First thing, it's defined as membrane-bound vesicles with loose and electron-dense particles found in extracellular locations. Measurements about 80 nanometers. Most often found in patients with a membranous, lupus, FSGS. Now, unlike deposits, they have a double membrane. Thought to represent in the 90s nuclear poor organelles. They found out pretty quickly, not really true, and they used immuno-EM, which demonstrated that Vimentin stained for C3, C5b9, that this is not actually an immune deposit. This is something else. So how do patients present with podocyte-unfolding glomerulopathy? It's mainly reported in the East Asian Japanese literature. Present with subnephrotic, 75%, nephrotic syndrome in about 25%, females over males. 70% have an associated underlying autoimmune disease. The other 30%, 60% of them have a positive ANA. So it's associated with autoimmune disease in some way. Now, the histology can show minimal changes, FSGS and membranous-like. So I'm not going to go back, but when I was pointing at the holes, those are in the podocytes. Those aren't actually holes. And the only time you see anything, or when you cut these en face, you see what they call bubbling. And I'm sorry, I'm just not good at computers that I couldn't blow this image up, but that's kind of what we see. And it's really important to divide it into two groups. It's either immune-mediated or it's not immune-mediated. It's idiopathic. So if it's immune-mediated, a lot of people say, well, just call it a membranous with microspherules and podocyte infolding. If it's non-immune-mediated, that's where we start to get into idiopathic podocyte infolding glomerulopathy. So the electron microscopy is what defines this entity. You cannot make the diagnosis without EM. So thickened GBMs, complete podocyte foot process effacement, infolding of the podocytes, clusters of microspherules. You can't talk about membranous nowadays without mass spec. I mean, you just can't. So what they have found in the cases that they've done mass spec on is they haven't found a actual protein. What they found is that actin is actually decreased, and so is tubulin B4. So there's some degeneration of the actin cytoskeleton. So the current theory of what they call PIG, podocyte unfolding glomerulopathy, is you get podocyte injury from autoantibodies, causes injury, dysfunction of the autoantibodies, entrapment of degenerated things. So, I mean, as you can see, I'm quoting the Indian Journal of Nephrology. This is really described out in the Eastern culture. And so we get autoantibodies, we get infolding, and then we get the microspherules, microtubules. So treatment, the thing to know about this entity, it responds remarkably well to steroids. High-dose steroids, 90% respond. 45% partial, 45% complete. Immune complex related PIG, more likely to respond than idiopathic. This is a controversial entity, especially in this country. We are very slow to adapt. In this country, we will call it membranous with microspherular deposits, even if we have trace staining for IgG. Trace. So a paper from Cedars-Sinai traced to 1+ on a 4+ scale. That's almost making up something. On the Rochester group, it was a 1+ out of 3+. So very slow in this country to actually adopt this entity. Also, we see it a lot in lupus, class 5. We think it could be underlying abnormalities in the GBN. Microspherules could be wear and tear. So there's a lot of opposition, a lot. So the big opposition comes from class 5 lupus. So frequent subtype, which is associated with it. Now, the big thing is 3 cases where it was first renal biopsy showed class 5. When they did the rebiopsy, they found podocyte unfolding glomerulopathy. They go, well, it's just degenerating deposits. That's all it is. And microspherules, we don't usually see them. It's very rare. And that's why we have this membranous with microspherular deposit. So this is what we're seeing. Now, the cool thing about ultrastructure, we don't just have one type. We have scanning EM. And scanning EM has shown beautiful podocyte infolding. But this is where it gets interesting, is a new technology. So this was back in 2016. They took a bunch of mice and they looked at the interaction between the podocyte and the underlying GBM. And they started to discover you saw podocyte protrusion, infolding, however you want to call it, invading the GBM in Alports. So this is what we see in Alports. It kind of looks like it, kind of doesn't look like it. But the big thing about Alports, you have thick, thin, basket weaving, all this stuff to make me sound smart. But the beauty about it is it really makes us understand what's going on in the GBM. Because what makes up the GBM? Alports, alpha 3, alpha, you have collagen 4, subunit alpha 3, 4, or 5 is mutated. Usually we think of alpha 5 mutated in the X-link, but alpha 3 can be mutated and all that. But the thing I didn't know, which I learned, podocytes are the only cell in the kidney which actually express collagen alpha 3, 4, or 5. I never actually knew that. So what it means, and let me go there, see how we have this beautiful membrane, and then we have all this stuff in collagen 3, 4, and 5. This could be the podocyte or the endothelial cell. You flip it, the same thing goes up. There is a lot of space between the podocyte membrane and the collagen. And so what they found, or what we see in embryology, is we actually see what actually produces the collagen 3, 4, and 5, or collagen 4 subunit 3, 4, and 5 is the podocyte. So now we're starting to go, wait a second, maybe this is just a type of repair. So, oh, my great slide is not there. Oh, here it is. This is beautiful. The crumbs of Leopis. You know what those actually are? Podocyte infolding. This is what this study showed in mice. This is podocyte infolding. And as we know with Alports, you don't start with proteinuria. You don't get it till way later. And this is one of the explanations of why we think you don't get it till later. So what they did is they took mice, and basically the blue, the magenta, and the green are two different podocytes. They're just adjacent. And this is where we start to do the scanning EM reconstruction. And what they did is they took mice who have wild type. You don't see any infolding. You see alpha 3 subunit, which is if you knock out 2 of them, then you get Alport's disease. And what they found is in the aged mice, the length of the podocyte invasion actually increased as you got older. So just to show you, here's a young mouse, very rare that you see any podocyte. Here's the adult. You start to see this podocyte invasion. What's actually happening, we think, is it's actually trying to lay down the collagen 4, alpha 3, 4, 5. And here's the aged mouse. And you can just see how irregular this membrane is. So we flipped it, and this is, it's just really cool to look at, because as the mouse gets older, you see the infolding gets deeper and deeper into the membrane. And so they go, great, this is Alports. They took other mice, FSGS, congenital nephrotic syndrome mice, and they found the same exact thing, that it's just not in one disease. We're starting to think that in thickened membranes, this is one of the reasons that you get proteinuria. It doesn't make any sense why you have a thick membrane, you get proteinuria. Always been assumed it's because of the negative charge. We're finding out now by proteomics, not completely true. So what we're starting to think after using this technique is that type 4 collagen is in the center. Podocytes are actually remodeling the GBM damage from altered filtration forces. And we've known for years this matrix metalloproteinases are released from podocytes. And that's what causes the protrusion. So it's actually an active process. It's not a process where you just get stuck in the membrane. This is actively occurring. And that clear area that we see around the podocyte, that's actually from destruction of actin. This is the way it's burrowing or going into the GBM. And we're starting to think of something called invadosomes. This is something that we see in collagen, where it actually goes and destroys the actin to actually get deeper to repair a collagen tear. And if you look, the GBM age and collagen age, 100-day turnover is pretty similar. So this is kind of where we're moving. So just a little short thing, newly recognized entity, protrusion of podocytes into the GBM, and it's an incredible way for us to actually see what's going on, how the GBM and the podocyte actually interact with each other. So these are just some pictures. This is actually a membranous, a normal membranous, but this is the podocyte unfolding glomerulopathy. Unfortunately, and I'm going to have to end on this, but this is actually a friend of ours. So she got rituximab and she got high-dose steroids, and she should have responded, but she didn't respond. So it's very tough. And they say, and my dad always told me, you never diagnose a friend. You never take care of a friend. Because the one time bad thing that happens when this happens. But my wife told me I need to look at the biopsy. And so blaming my wife. But at the same time, it's a very interesting entity. I'm not sure if this is podocyte unfolding glomerulopathy. I'm not sure if this is membranous with microspherular degeneration or deposits. At the end of the day, I just knew that they should treat it. And if anybody has any thoughts, that would be greatly appreciated.